This presentation is on the drug meprobamate. Here is its chemical formula. Meprobamate was the first drug to be sold specifically as an anxiolytic. Its synthesis began with a compound called mefenecin. Chemists and pharmacologists Berger and Bradley initially aimed to make a new antibacterial agent for gram-negative bacteria that wasn't responsive to penicillin. They did this by taking an already existent antibacterial called phenylglycerol ether phenoxyetol and linking its carbon chain. He believed that this would create an antibacterial effect he was looking for, but when he tested it on mice, he noticed that the mice exhibited a reversible paralysis of their voluntary muscles. In 1947, mefenecin was introduced clinically as a muscle relaxant to be used with light anesthesia by Malicin, as an alternative to tuberculin. However, it was limited by its short duration, weak action, and effect on the spinal cord. To combat these challenges, Berger and his colleagues altered the compound's primary hydroxyl group. In 1951, Ludwig and Peake created meprobamate, a compound that overcame the drawbacks of mefenecin. Its action lasted 8 times longer and was readily absorbed through the stomach. From 1955 to 1960, meprobamate became very popular and found its way into many of America's medicine cabinets. Meprobamate's success waned with the introduction of benzodiazepines in the 1960s. Meprobamate's pharmacokinetics generally exhibit first-order pharmacokinetics. Its peak plasma levels are reached between 1 and 3 hours after the drug is ingested. It's metabolized primarily by the liver, specifically its inactive metabolites. Then 10 to 20% is excreted in the kidneys. According to a 2013 study, its half-life has been observed to be between 6.4 hours and 16.6 hours. Meprobamate's pharmacodynamics label it as a Schedule IV anxiolytic drug because it acts as a CNS depressant. It works by modulating GABA A receptors and exhibits negligible protein binding. Its side effects include drowsiness, lethargy, and an unsteady gait, similar to other CNS depressants like alcohol and benzodiazepines. High-risk use behavior of meprobamate is similar to other CNS depressants and include alcohol use due to alcohol's effect on the central nervous system, taking more drug than prescribed, driving while taking meprobamate, and impulsive behaviors. Meprobamate is an anxiolytic drug that was regularly prescribed for the treatment of anxiety in the 1950s and 60s. It's no longer prescribed as a first line of defense for anxiety, but it is still prescribed and used in Europe and North America. In addition, meprobamate is a metabolite of the drug cariprazole, a muscle relaxant. Notably, France and the United Kingdom withdrew authorization to market meprobamate in 2012. This change led to several research studies observing its use before and after the withdrawal. Research in this literature review covers topics such as treatment of withdrawal symptoms, changes in mortality after the withdrawal, and prevalence of accidental exposure from drinking water. Studies on meprobamate withdrawal are very limited and primarily rely on case studies. In one study published in 2016 by Alexander Owen James, a 70-year-old patient with 45-year history of meprobamate dependence was medically treated for withdrawal with diazepam. The patient was experiencing withdrawal symptoms of anxiety, severe nausea, and vomiting, following 2 attempts at medically assisted titration off of meprobamate. During this treatment, the patient stopped taking the meprobamate immediately, and his symptoms were controlled using the diazepam. According to this research, a majority of people prescribed meprobamate experienced these same withdrawal symptoms, with few experiencing effects as extreme as grand mal seizures. A 2020 case report by Zink and Erickson examined the treatment of a patient exhibiting seizures as a result of meprobamate withdrawal. Prior to experiencing the seizures, this patient had complained of nausea and trembling. Because benzodiazepines were ineffective at controlling this patient's withdrawal symptoms, a reintroduction of meprobamate along with phenobarbital were prescribed. Withdrawal from meprobamate can occur at regular doses, as low as 1,200 milligrams per day, which is considered a typical therapeutic dose. Withdrawal symptoms typically occur following prolonged use of the drug, but they have also been observed in patients taking meprobamate as few as 40 days. Both of these studies were limited by available participants due to the low number of people being prescribed the drug. However, methods for addressing withdrawal symptoms seem to be relatively varied, particularly with regard to the meprobamate itself. Whether or not a provider continues to prescribe meprobamate in decreasing amounts as the patient receives treatment varies by a case-by-case basis, and there are no long-term studies to determine which treatment is the most effective. Studies on meprobamate overdose are similarly limited, but they do include more concrete measurements and treatments. One study observed the effectiveness of continuous veno-venous hemodiafiltration, or CVV-HDF, on a patient who had experienced cardiovascular collapse and respiratory failure due to an overdose of meprobamate. The patient made a full recovery after 36 hours of CVV-HDF, and researchers were able to use this case to learn about meprobamate's pharmacokinetics. Specifically, researchers found that meprobamate's half-life using this treatment was approximately 6.6 hours. Another study examining the effects of meprobamate overdose was conducted on a larger sample size of 59 patients who all had plasma concentrations of the drug over 20 milligrams, with typical therapeutic doses ranging from roughly 10 to 25 milligrams. Researchers used the Glasgow Coma Scale to determine the severity of overdose symptoms correlated with the meprobamate plasma concentrations. They found that the plasma concentrations for those in severe comas ranged from 37 to 177 milligrams. Researchers noted that it is possible for conscious patients to have high concentrations of the drug in their systems due to tolerance developed to the drug over time. Despite the lack of statistically significant correlation between symptom severity and concentration, researchers maintain that it is important to determine meprobamate concentrations in overdose cases in order to determine appropriate care. I believe more research is needed on the treatment of meprobamate overdose. Research involving treatment outcomes using variables of both symptom severity and level of dependence would be useful because it would eliminate variability caused by tolerance. In addition, researchers in both overdose studies mention that meprobamate causes similar overdose symptoms to other benzodiazepines, so it can be difficult to ascertain which drug has been used in an unconscious patient. In France and the United Kingdom, researchers have been observing changes in morbidity and mortality of meprobamate since the withdrawal of approval from the government to market the drug in 2012. The study found that meprobamate did not reach zero in the 12 months following the withdrawal, but the number of patients exposed to the drug did decrease by 86.8% in France and 15.2% in the United Kingdom. Researchers estimate that withdrawing meprobamate from the market altogether could prevent up to 1,558 cases of severe hypotension. This study exhibits the impacts policy changes can have on drug use. However, the study did not mention whether previous users of meprobamate stopped using CNS depressants entirely or began using a similarly functioning drug, such as a benzodiazepine. In addition, I'd be curious to see additional research on the impact of direct-to-consumer marketing of a similar drug and its impact on cases of overdose and severe hypotension. Another example of policy interacting with meprobamate use is a study conducted in 2000 to examine the effects of meprobamate on driving. With a sample size of 104 drivers, this study found that meprobamate had similar effects on driving to other CNS depressants such as alcohol. However, meprobamate was found to be the only drug in the driver's system in only 21 of these cases. Of these 21 subjects, impairment was found to be present at as low as 10 milligrams, which is the low end of the therapeutic range. Because of this, there's a significant ethical responsibility of both providers and patients to use care when prescribing or taking meprobamate or carisoprodol.